So I think in high-risk MDS, we had significant improvements with the introduction of hypomethylating agents, azacitidine and decitabine. In case of azacitidine, has been shown to improve overall survival. But we know with both of these drugs, the duration of response is generally limited to 12 to 18 months. The median survival has been shown in real-life analysis not to be more than 18 months for most patients. And we know most patients will not achieve a complete response. Only 20% achieve a complete response. And once these drugs stop working, the survival is only around 6 months after HMA failure. So for all of these reasons, it's became clear to the community that we need to improve upon the existing therapy of high-risk myelodysplastic syndromes. And there has been a number of trials that have tried to add the drug to azacitidine or decitabine to improve on outcomes. But most of these have failed once they have got into the randomized phase 3 setting, with the most recent failure being Verona trial with venetoclax. So we tried to explore other ways of targeting MDS, and we chose to use an immune checkpoint inhibitor called Bexmarilimab. So Bexmarilimab works on a target called Cleaver-1. What is Cleaver-1? So Cleaver-1 is a receptor, it's a scavenger receptor that's involved in the innate immune system, as well as tissue damaged tissue clearance. And this has been shown to be overexpressed in macrophages in patients with cancer. And it leads to an immunosuppressive microenvironment in the bone marrow. It has been associated with worse survival when it's overexpressed. And targeting it in preclinical models has been shown to convert these macrophages from an immunosuppressive macrophages to pro-inflammatory that can target the cancer cells. And indeed, we took this preclinical experience to the clinic, where we are testing the combination in a phase 1-2 study in patients with higher risk MDS to explore if that will lead to clinical benefits of patients. Yeah, so this is a phase 1, phase 2 trial that also used a number of doses. So it involved dose escalation as well as the dose optimization part. And we enrolled a number of patient populations. So enrolled patients with acute myeloid leukemia who are unfit for intensive chemo, as well as chronic myelomonocytic leukemia and high-risk MDS. The abstract that was presented in ASH focused on patients with MDS with high-risk disease, both in the front line and the the HMA failure setting. So the patients were required to have a pathologically confirmed MDS with good organ function, as well as being adults. And for the refractory relapse patients, they were required to have basically been refractory to hypomethylating agent therapy. Yeah, so I think in the responses in both in the frontline setting and the refractory setting looked promising. So we reported in a total of 55 patients, 21 of them were in the frontline setting and 34 patients were in the HMA failure setting. So in the frontline setting, with a relatively smaller number of patients, 21 and limited short-up, we observed good safety. So the drug was well tolerated. The side effects were along the lines of what you see with azacitidine, primarily count suppressions. There was no Bexmarilimab related deaths, and very limited number of immune infusion reactions or immune mediated adverse events. In terms of the efficacy, we saw, I think, encouraging efficacy of the combination with a composite CR by the IWG 2023 criteria of 55%. The CR rate was 29%. And response rate by the IWG 2006, the old response criteria, was even higher. In the relapse refractory setting, we also have seen responses as well as transfusion independence, indicating clinical benefit in a very difficult to treat patient population. But importantly, the overall survival in the refractory relapse setting looked quite promising at 14.5 months compared to what we historically have seen with HMA failure, which is around 6 to 8 months. In the frontline setting, the overall survival is still a short-term follow-up because the follow-up has been only for a median of 9 months. So the overall survival continues to mature. We are still exploring the immune kind of activation aspect of the drug using the samples we have collected on the study, but I think we have observed interesting features. For example, we have observed that in patients who have TP53-mutated MDS, which tends to be a very difficult patient population to treat, we have seen responses that looked similar or even better than the TP53 wild in terms of the frequency. For example, in the frontline setting, the patients who had TP53, 70% of them had complete responses. The duration is very important. TP53, we are still following these patients. Some patients were able to proceed to transplant. Translationally, we have observed the increased expression of cleaver-1 to kind of correlate with the chance of achieving a response. So I think some of these analyses are still ongoing, and we'll be reporting on these in future meetings.